From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello and welcome to our listeners around the world. You're listening to JAMA Author Interviews. Thanks for joining us. I'm your host, Dr. Christopher Seymour from the University of Pittsburgh, and I'm delighted to be joined today by two amazing scientists, Dr. Emily Moin and Dr. Scott Halpern from the Palliative and Advanced Illness Research Center at the University of Pennsylvania. Today, we'll be discussing their new original investigation in JAMA titled Use of Life Support and Outcomes Among Patients Admitted to United States Intensive Care Units 2014 to 2023. Welcome to you, Emily and Scott.
Thanks so much for having us. It's a pleasure.
So when I saw this manuscript, I was just excited because it's fantastic to see new data about the way we practice medicine. That includes both those in the intensive care unit, those on the medical ward. And I think there's some really interesting findings in this paper. But before we get to those, tell me a little bit about why this question and why now? What prompted this study?
I think that your comments are really apt and match how we felt as the authors starting to craft this work as well. I think it's probably an understatement to say that the past 10 years in medicine have been eventful, and I'm biased as a critical care medicine physician, but I think especially eventful in critical care medicine and in the intensive care unit. So for us, we wanted to better understand, while we saw kind of the visceral feelings of how things had been changing over the past 10 years, we wanted to see how those trends were reflected in the hard data and better describe them and make sure that what we thought that we were experiencing, what we thought we were seeing, was reflected in that analysis. We just marked the 5-year anniversary of the WHO declaration of the COVID-19 pandemic, which happened to be part of that 10-year period that we were analyzing. So we wanted to understand better in that broad nationwide scope that we brought to this analysis how the pandemic affected those care practices and outcomes, and then also contextualize that period leading up to the pandemic, because as you said, these outcomes, these measures haven't necessarily been updated in the critical care literature since around 2010, 2012. And we wanted to see how those trends had continued.
Okay, so it seems like it's been a long time since the ICU community has had strong epidemiologic data on critical care use. You'd said almost back to 2010. So when you were approaching this question, then what data sources were you going after? And tell us a little bit about that.
This was an example of really synergy, kismet, whatever you want to call it, because around the time that we were starting to ask this question, Dr. Halpern and I first gained access to the Epic Cosmos database, which for our listeners who may not be familiar with it, Epic Cosmos database is a data set that's maintained by Epic, the electronic health record company. If any of our listeners have ever used the Care Everywhere feature in Epic, then it's sort of intuitive to understand what the Epic Cosmos database includes. So participating organizations will transmit their clinical data about patients into the Epic Cosmos database, and then Epic uses a data pipeline to sort of harmonize that information. So what's fairly unique about this data set is, number one, that it includes really rich clinical data, so not just the types of data fields that you would find in, say, an administrative data set that you might be more likely to use for a nationwide investigation like this, but also that patients are sort of harmonized across health systems. So if a patient is seen at a hospital in Texas and then a year later seen at a hospital in California, Epic is most of the time able to recognize that that's the same person with the same rich history, the same comorbidities, all of that information that we leveraged to, I think, make this analysis much stronger than it would have been if we didn't have access to the Epic Cosmos database.
That's great. And it sounds like it took quite a bit of collaboration to get access to this data. And certainly that's quite unique. Scott, tell us a little bit about the representativeness. It sounds like maybe there was data from every state that went into this analysis.
Yeah, And I think that's one of the really key features here, Chris, is, epidemiology as a discipline at its core principles is based on describing phenomena accurately. And then advanced epidemiology gets into methods of causal inference. And somewhat paradoxically, I think that in the field of critical care for at least a decade, if not longer, we've gotten increasingly sophisticated in using causal inference methods to understand facets of how we provide care and how those care practices relate to outcomes in the intensive care unit. And we've made almost no progress whatsoever in the basic descriptive epi of the care we deliver. So what really was motivating here, and I think Emily hit the nail on the head, is the fact that EPIC accounts for about 26% of all inpatient admissions in the United States. That's a massive number. And the fact that, as you articulated, it includes patients from all 50 states, as well as the District of Columbia. And we're not just talking about a few patients in any given state. If I remember correctly, there were several thousand patients from each of those 50 states. And with demographic characteristics that look just like America, and all of the other things you would hope for in establishing a representative data set. So arguably, really for the first time, we've been able to answer these sorts of, fairly basic but fundamental questions regarding how we practice using data that really reflect the country as a whole.
So then it's almost a nice segue. Emily, what are the main findings of the analysis? I'd love to hear those take-home points.
We sought to understand a few different, as Scott was saying, really basic fundamental things about the care that we deliver in the intensive care unit and the outcomes of our patients. So first, we wanted to look at in-hospital mortality, kind of the ultimate outcome, many would say. We also wanted to understand changes in ICU length of stay because that's a metric that is often used in critical care trials and is also of great importance to stakeholders in the administrative space. And finally, we looked at receipt of life support interventions, in this case, invasive mechanical ventilation and vasopressor medications, because those are the most widely used indications for intensive care unit admission. So starting with in-hospital mortality, as we were saying earlier, some of these measurements have not really been updated, I would say, in the past decade or so. And if you had asked us prior to doing this work, we would say that the literature have demonstrated that over several decades, there has been a downtrend in hospital mortality among patients receiving care in the ICU. What we found, rather, in this study was that starting from around 2014, the period when our study began, in-hospital mortality for patients who received ICU care was relatively stable up until the COVID-19 pandemic. We saw there was a lot of seasonality, which is something that has been known about ICU care and outcomes for a long time. The winter brings with it flu and pneumonia and other increases in severe illness. But overall, year to year, in-hospital mortality seemed to be fairly stable, again, up until the COVID-19 pandemic. During that time, when we stratified our measurements by the COVID-19 so-called status of our patients, so whether they had tested positive for COVID-19 either during or just prior to their admission, we found that all of those patients experienced increased in-hospital mortality relative to that period leading up to the COVID-19 pandemic. So whether you were hospitalized with COVID-19 critical illness or not, the in-hospital mortality that was experienced during that time period was elevated. But among those who were COVID-19 positive during or just prior to their hospitalization, the elevation in in-hospital mortality was really significant, I think surprising even to those of us who lived it and took care of patients in the intensive care unit during that time. We found that the adjusted odds ratio for in-hospital mortality among COVID-positive patients was 4.3, which I think is a number that's just staggering. The COVID-19 pandemic was devastating. And nonetheless, that number surprised us.
So, Emily, what happened to these important indicators of ICU outcomes after the pandemic?
So what we found, I think reassuringly, was that for the most part, these indicators returned to their pre-pandemic baseline after the pandemic. And one of our findings that was quite interesting was that although we chose in our study design to define the COVID pandemic period based on the WHO, statements by the US president, sort of rigidly define that period, we found that some of those indicators kind of naturally returned to their baseline somewhat earlier, which I think is in keeping with the experiences of many in our communities and also in keeping with some of the early literature that has started to be published describing that late pandemic and post-pandemic period. But there were some differences that have persisted, which I think will be really interesting to observe and study in the years to come. Notably, there was a lot more use of invasive mechanical ventilation during the COVID pandemic, which I think is totally understandable. We would hypothesize that that's most likely due to the sheer number of patients experiencing respiratory failure throughout that period. But since then, we've seen that the use of invasive mechanical ventilation has actually declined, not just back to the baseline of the 20-teens, but actually quite a bit lower than that. So we've hypothesized that maybe because physicians became much more comfortable with those alternative therapies for the support of patients with respiratory failure during the pandemic, perhaps out of necessity. If you don't have a ventilator to offer, you might be more likely to reach for something like non-invasive positive pressure ventilation, but perhaps also because of some early work that has suggested that those might be more beneficial or at least non-inferior to invasive mechanical ventilation.
Thanks, Emily. So then what about vasopressors? There's been quite a bit of interest in maybe administering these through peripheral, intravenous access. There may be interest in starting vasopressors earlier than we would have expected a decade ago. How did those trends look?
I think you hit the nail on the head. The vasopressor trend that we found in our data, I think, is one of the most surprising to us, at least. We saw that vasopressor use increased not just a little, not just subtly, and certainly not just during the COVID pandemic, but it more than tripled over the course of the 10 years. And that increase started and, in fact, increased the most well before the COVID pandemic. I think that the reasons that you cited are probably involved. So we have seen a lot of smaller regional or single center studies describing increases in the use of peripheral vasopressors, a lot of interest in the safety of peripheral vasopressors, as you said, earlier use of vasopressors perhaps rather than large volume resuscitation with crystalloid.
Scott, when we think about these findings, I'm curious what surprised you the most? What was sort of an interesting take home from your perspective?
I'll actually start with what was an interesting take home that was not surprising per se, but was, I think, important for our community to see. So for years, we've been talking casually, like around the water cooler, about how the patients we're caring for in ICUs keep getting sicker and sicker. And indeed, if you look at our data, you see progressive increases in the median age of patients in the ICUs, the median comorbidity burden, and even the degree of physiologic compromise that patients are presenting with. And I think in a lot of ways, these data are validating of the gestalt that many of us who practice critical care medicine have held for quite some time, but have not had nationally representative data to back up. So the fact that this was true across the country is also important in that regard. It's not just the ICUs that the three of us practice in. It's a real phenomenon and a generalizable one at that.
You're also hinting a little bit that the EPIC data allowed you to in a very detailed way, measure the illness severity, the case mix, and the sort of physiology that was going on with the patients, different perhaps from more an administrative data source.
Yeah, the Epicosmos dataset has a few features that make causal inference methods tricky, but also has a number of features that make the potential for high quality risk adjustment possible. And I think it's very clearly shown. Emily spoke about the data on ICU mortality rates. If you look at just the raw mortality rates, you actually see big differences over time, almost a 50% increase on a relative scale going from the pre-pandemic period to the pandemic period, and then a return not all the way to baseline. But when we then risk adjust, that's when you see the relatively stable in-hospital mortality rate prior to the pandemic, still elevated during the pandemic, but getting all the way back to baseline post-pandemic. Again, because patients are getting sicker, but if you address that with risk adjustment, you see that the overall odds of dying haven't changed at all.
So then, Emily, hearing and considering these findings, I'm curious what you see as the next step. Where do we go in terms of this research? And will EPIC just keep getting bigger and giving us a better view? What are your thoughts?
I think that, as Scott was saying, we've elucidated some findings that help to sort of quantitatively or empirically confirm those water cooler conversations, those trends that we think we've been experiencing but haven't necessarily been able to demonstrate just yet. So the next step is really to go deeper, to understand better what's happening in more detail, how it's happening around the country, because certainly if there's one truism about ICU care, it's that there is a lot of practice pattern variation from site to site. And then to understand how those changes are affecting our patients, because that's really at the end of the day why we do all of this, is to deliver better care and improve outcomes for our patients and our communities. I think the question of the changes in vasopressor use are especially ripe for future investigations to understand what's really been driving that. Have there been safety changes as a result of the increased use of peripheral vasopressors? And whether a large database like Epicosmos that, as Scott mentioned, has some understandable limitations that can make causal inference more challenging, but whether that can help us to appreciate some of those associative or more causal questions.
Excellent. Okay. Well, I'd say we leave it there. I'm excited about this paper. It's going to give us a sort of state of play, both before and after the pandemic, for our ICU communities, colleagues, and other stakeholders. And so thank you for joining me.
Thank you so much for having us. It's a pleasure.
I am Dr. Christopher Seymour, and I've been speaking with Dr. Emily Moin and Dr. Scott Halpern from the University of Pennsylvania about their new original investigation, Use of Intensive Care in the United States. You can find a link to this article in the episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.